I want to welcome you to the podcast. I'm Dr. Deborah Durst. I am a double board certified physician that now specializes in regenerative, metabolic, and nutritional medicine. As a return viewer, I want to thank you. I love all the feedback and comments, and we love interacting with them. If you are new to the channel, I hope that you love all the content we're putting out. Please like, subscribe, share with friends, and leave comments so we know what you want to hear about because we are willing to deep dive into anything wellness or sexual medicine. Thank you. Welcome back to the RMD podcast with me, your host, Dr. Deborah Durst, and my co-host.
Hey guys, Farida Golombieski, nurse practitioner here at Revitalize MD.
So today we're going to talk about the popular weight loss agents of Mounjaro and Ozempic. And again, is there truth behind all the hype?
And what is the hype, right? It's also known as Wegovy or
Ozempic.
Ozempic.
Yeah.
Ozempic's the other one.
So Semaglutide is Ozempic and Mounjaro is Tirzepatide. And those two agents are more recent weight loss agents. And so, again, there's a lot of hype around it. And you see that on social media, you see it on YouTube, everywhere. On the news, there's nowhere you don't see it.
Exactly. And I think they're interchanged a lot, but there are some important differences between the two medications.
Yeah, correct.
So we'll talk a little bit about those and how they're utilized and what the hype's all about.
Correct. And so, what are these agents? What's the difference? What's the hype? And what's the real issue? I want to know. What are the headlines right now? Because they get, I guess, more in depth every day. The sagging has been a thing. The Wegovy, the Ozempic face.
The Ozempic butt.
Yes.
Right?
The sagging, the plastic surgery you're going to need. The Kim Kardashian's plastic surgeon, it has done more surgeries since, the use of these agents. So
And then big warnings, right? Everything's around. It's how bad it is, how terrible it is. So what is the truth behind that? What are these, we'll get behind these myths. What's true? What's false? What can be true, right? Because some of it has some validity to it, but it's extreme cases.
I think it's always about context, right? So I think that there's context to that. So we're going to first go over obesity. So again, obesity is a huge issue. And no matter how we look at it, no matter how we want to make it okay, it is a health hazard. And there are diseases that come along with it. Again, there's a big, huge cost. So 650 million people worldwide with obesity and 147 billion in dollars in the US alone for obesity.
So when we talk about obesity, we're talking about BMI over 30. We're talking about people that may or may not have other comorbidities, but obesity tends to lead to having more issues like increased blood pressure, hypertension, blood sugar controls, issues like diabetes, trouble with cholesterol or hyperlipidemia. So these are all other comorbidities that have a negative effect on our health, including our cardiovascular health.
Yes, correct. And, again, if you think about it, fatty liver, that leads to different things. If you look at, and again, when I was in the ER, knee pains, knee surgeries, back pains, and discomfort. So if you have a skeletal system and now you have a lot that is on the skeleton system, like your knees take more abuse. So when you have knee pain and you have joint
Hip
issues,
pain, ankle.
it is more likely when you are carrying a lot of weight. And likewise, your back is compensating for, what we might have on the front. And so you're balancing it, so your back likewise can cause increase in pain. So there's lots of issues. So traditionally, what have we had to treat it? Not anything that really worked all that well. And so we've had medical treatments for a long time, but they just really haven't worked. And lifestyle interventions, we can say,
you need to eat better, you need to work out. And I think that is a cop-out almost, right? It's really easy to tell someone, eat better, work out.
Correct.
But then how much of that actually translates to real life, and then how much of that is actually leading to weight loss?
Correct. Well, and I think the fact that lifestyle interventions such as nutrition and fitness have not always resulted in the weight loss. So it means that it's a more complex
Yep.
metabolic, metabolic issue. But I look at, like, again, common sense wise, like, we kept fast food chains open during COVID.
Yeah.
So it's not exactly as if we are giving people the tools that they need.
No, it's
Period.
easy to
Across the
grab
board.
something through the
Yes.
drive-through when you're running 15 different directions with your kids or your family or work.
Correct.
So it's the easy option. But also in traditional medicine, we don't have a lot of time to sit down and actually go over what does good exercise look like? What does healthy eating look
But
like?
they don't have the time.
It's quick.
Insurance, yeah, you have a quick visit, you're allotted so much time for it. The reimbursement is very limited. We don't have nutritional services that are on a regular basis reimbursed. We don't have fitness trainers that are reimbursed. So the things that really make a difference for obesity and the costs related to it and the morbidity, mortality is not there. So are we supporting the lifestyle habits that need to change to get people healthier? And the answer is absolute no, because again, I remember doing, and it wasn't too long ago, but like a juice cleanse, for instance. I had to sign a waiver for a juice cleanse.
Really? I bought
Yes.
mine online.
I never had to sign a waiver at McDonald's.
That's right. That's a very valid point.
Yeah, so again, like the common sense is not there. Like we are not supporting that, so it makes it seem as if we're not looking to have a healthy, like population. And so what happens with, again, the GLP-1s or these agents we're talking about, Mounjaro and Ozempic. And again, Mounjaro is Tirzepatide, Semaglutide is Ozempic, and these agents are GLP-1 agents and agonists that work, and those are, again, nutrient sensitive, hormones in the body. And so basically, as those started to get approved, and that started in 2005 with the first
So
one.
a long time ago.
Long time ago.
With Bayetta, I believe, was the first one.
Yeah, so it went way
And
back.
then Trulicity. And, those were earlier versions of these GLP-1s.
Correct. And then Wegovy and Ozempic being, the first GLP-1 that really that I saw a lot about.
Well, because it was the first one to really see a big jump where we're seeing, 3 and 5% body weight changes, and now we're jumping to 12 and 17 and 20%.
When we talk about meds that have historically been used in traditional medicine over time, we're talking about like a 3 to 8%. And so those early agents were very equivalent to that. So it wasn't like sticking out as, something that was way more effective than the usual treatments. And surgeries were up, 25 to 30%. And so
And traditionally, a 5% body weight change is considered statistically clinically proven as a positive. So that's like gold standard, right? If we could see a 5% body change, we are happy. That's a significant change in weight.
Yeah.
And now we're seeing 12 to 20% body change.
Correct. And so up to 25% in some of those, like, equivalent
in some of those studies,
So meds and surgery were what we offered, and then the meds just got better. And again, these meds were better in approaching surgical results, which is why they have caught attention. And again, it's the first time that I ever saw, and I was a pharmacist before I went back to med school, first time I ever saw a specific, ingredient remarketed, like the same ingredient remarketed for a different indication. Apparently can happen. It has.
Yeah, because semaglutide is Ozempic indicated for diabetes and Wegovy for weight loss.
Correct.
And then the same is with Tirzepatide.
Yeah.
So Mounjaro for diabetes, and then the other one, I forgot.
Yeah, I forget too. But again, because it's not seen as often. But they're different brand names for the indications of diabetes versus weight loss. So the other thing that is a big hype, though, is that these agents are no longer available for the people that want them. So now that we're using them for weight loss, there's no longer, the availability for diabetics. There are two different agents on the market for that. And again, those are manufactured. So same ingredient, but manufactured And those are coming from a regular pharmacy with strict indications for insurance coverage, which again, you have to be with a BMI greater than 27 and a health condition related to it to get it covered. Otherwise, it's very expensive out of pocket. So, and if you fall back below the 27 or your hemoglobin A1C is moving back to
Below
the
that 6.5, which
Yeah,
is
so
6.5 and above is diabetic.
and so if you actually
lose coverage.
improve in your hemoglobin A1C, then it's no longer covered until you are now again out of range.
I've heard all kinds of crazy things from patients.
So have I. So again,
But to touch back, it's Zepbound
Yes.
is the Tirzepatide
I
FDA
knew you
indicated
weren't
for weight
gonna let
loss.
that
I
go.
couldn't,
No,
had to pull it back up. It's just
Yeah.
not one we hear a ton about.
And I couldn't remember it. I just knew they were different names. So yeah, she's
Had to go back.
persistent. Yeah, I love it. So, but I think again, so these agents were effective, and so they have been remarketed for weight loss and diabetes. So it's actually FDA approved for weight loss. Again, you just have to meet specific criteria for it. So there's a lot of hype around that too. We're using them for things that, and taking away from, the need for diabetes, but they're actually marketed and those are FDA indications for it. But what we're using are compounded versions of those. And again, we never did weight loss across the board at Revitalize MD. We didn't do it because, again, we always believed in lifestyle changes.
And we still don't really do just weight loss.
No, correct. We don't.
We
And
do
the issue,
comprehensive treatment plans that include weight loss and healthy lifestyle changes.
well, and we always did peptide. We have done peptides for a while for other reasons, and our patients kept coming to us because they were on them at other places. And actually, like again, $1,200 out of pocket. I kept hearing way back at the pharmacy. So they were looking for other options, and we were doing
1,200
peptides.
plus or 12,000 plus a year
Yeah,
without
so-
insurance coverage.
And it was about an average of $1,200 a month that patients were saying they had to pay. And so we started
doing our research on our end,
investigating it.
right?
Yeah.
As you do as a provider, you go, okay, patients are bringing it to me. Have you heard anything? Yes, I'm hearing it too. So we did our research and we
Correct.
went to conferences and listened to other physicians talk about it and protocols. And
Yeah,
it blew
as
us
we
away.
slowly implemented it,
Yeah.
but comprehensively with with a plan of action. And there were lots of places, again, especially med spas, and we're not a med spa, that would start doing peptides just for those weight loss. So lots of, trending of those pop-ups that are doing peptides. But again, we love peptides, but for other reasons, lots of reasons. But these are interesting agents, again.
Yep.
So the difference between semaglutide for the generic version and tirzepatide is that one is just a GLP-1,
Which is semaglutide
Yeah.
or Ozempic.
glucagon-like peptide 1, or again, glucose dependent. Now I always get this wrong because it's a GIP, and so glucose dependent insulin-tropic peptide, so it's longer. But anyhow, that is the second part of it. So it has a second agent in it. In simplicity, if you have two agents, one is more effective than the other and also has neuro effects, like your brain's hungry or is no longer hungry, and your gut is sending out hormones that are no longer hungry. These agonists cause that, and tirzepatide has both of those agents in brain and gut, and a more effective ingredient. So just more effective.
So we're seeing
the
higher
board.
weight loss, higher fat loss percentages with tirzepatide over
Correct.
semaglutide when clinically indicated to prescribe that.
Correct. And again, it's taking it into, there's lots of things that we can unpack here. So
I know. I'm like,
there
it's so hard because every topic kind of hits on three other topics.
Yeah, there's a lot of things to unpack. So the bottom line is that tirzepatide also has way less in the way of side effects. And so if I looked at the early studies, I thought they almost looked a little like distorted in the effectiveness with the decreased side effects, but in practice, it is actually absolutely the case. It's more effective
That's it.
and way less in the way of side effects.
We were slow to
side
start
effects.
tirzepatide because of the hypoglycemia effects we were worried about. So the dropping in blood sugar because of some of the studies, because they are a little bit skewed. You got to look at dosing and who they're utilizing it on, how they're utilizing it. But really, we're not seeing that clinically. we're seeing better results. We're seeing sustained results. We're seeing less muscle loss, more fat loss. They're both great for their own independent reasons, right? So we prescribe both, but Tirzepatide has been surprisingly probably
Well
more
tolerated with great results.
exactly.
I've absolutely been shocked. And again, I wasn't completely sure. There was a study again that Surmount one that showed there was 3 times the fat loss that there was muscle loss. And again, if you Google search that, it says that 33 to 36% fat loss versus 10 to 11% lean muscle loss or lean mass loss. And so that's 3 times the loss, but then it'll say 25% of that weight loss was muscle. So there's ways to frame this that make people more fearful. And I think that's what the hype is about. These agents work making it more fearful. But if you look at obesity overall, obesity in traditional medicine is considered a chronic intermittent disorder, the most common one worldwide. And so, again, I don't think us as a society, and we certainly don't have the obesity everywhere that we have here. So we have to look at what we have going on in the U.S.
Yeah. So
Like,
worldwide.
Worldwide, it's not the same, but worldwide, again, there's issues with that obesity, and it's chronic intermittent. But what happens if we want to just do, like, if it's somebody not meeting insurance criteria, not with extreme overweight with a BMI of greater than 25%? What if they have a smaller amount that they want to lose? And so, what if you're using it for a shorter period of time with a shorter weight loss
In
goal?
conjunction with nutritional
Correct.
advice,
Fitness, lifestyle changes.
absolutely. So those all play a huge role because anyone who loses weight that it isn't working out and eating protein is going to lose muscle,
Correct.
even if you're not on these medications.
Correct.
So if you just cut your calories back and lose weight because you're eating at a deficit, right? Calories in, calories out. If you're eating at a caloric deficit and you are losing weight, but you're not working out, you're not doing weight training or weight resistance, your weight loss will be fat and lean muscle.
Correct.
It's what it is. So when you have a higher percent of weight loss, you can see some lean muscle mass loss as well. However, if you're doing your protein intake and you're doing your aerobic workout and your resistance, your weight resistance, and you're doing your part, you can take these medications, meet your goals, be healthier, and not see that lean muscle loss at a significant deficit.
Correct. And a lot of, when Faraday's talking about weight loss, again, a quarter to a third of weight loss will be muscle just, with weight loss. And so, but if you incorporate this comprehensively, so number one, prescribed by a physician, followed on a regular basis, guided through that journey, and also have a comprehensive plan of how to address this from a lifestyle standpoint and
A
nutrition
hormonal
and
standpoint.
a hormonal, like you're doing it all. Because if you look at perimenopause and menopause or andropause, for men, we start to gain weight. That's a common thing. Like, we're going to gain weight. We're doing all the same things. So we have patients that don't have extreme weight issues, but are noticing changes. And if we're addressing them from a hormonal standpoint, but we want to add this as a agent that we're using in addition to, it's a matter of having conversations and guidance along the way, right? And
absolutely. And then what we're seeing is improvement in not only blood sugar, right? Because there is some insulin changes with this. We're seeing heart rates going down. We're seeing blood pressures going down. We're seeing healthier individuals with less pains, right? So across the board, their overall health status has improved, even if they didn't need to lose 50 pounds, even if they are not type 2 diabetic. They are healthier individuals and have less other
less comorbidities with
exactly.
it. Yeah. So I think that, like, again, we look at that weight loss that happens as we get older in perimenopause and menopause or andropause. So we already see that happening, and hormonal optimization is one part of that. because we start to see insulin resistance happen. We start to see blood pressures go up. We start to see metabolic syndrome. These are all known facts. Our
We see
hormones decline. We get
cholesterol's going up.
inflammation. Yeah, like your lipid panels. So these are all things that as our body ages, our hormones decline, we get inflammation in the body, and these are resultant effects of that. And then they're doing all the same things, but you need to have conversations. So if you look at perimenopause, menopause, andropause, and just intermittent fasting, that alone helps.
Yes.
So if
And we've done podcasts on intermittent fasting. You can always go back and look at our podcast on that if that's something that you're interested in. It is a fantastic way to help with weight management. But side note.
Correct. No, well, it's actually a perfect thing because I think it's important as we get older to think about that. And, different diets work for different people, but intermittent fasting works. There's actually lots of health benefits and anti-aging effects to that. And so I think if you're here and you have a goal you're here, this is your baseline, you have a goal, and it may not be those extreme numbers or chronic intermittent, but we have a goal, then we need to change our habits along the path to get to the goal, not use the agent as the strict reason for why we're getting to the goal, but instead we're using sometimes even a low dose. And if we look at the studies, which is why I said there's a lot to unpack, that's 10, 5, 10, 15, where they're in the studies using a higher dose of it.
So she's talking milligrams.
Milligrams, yes.
Very high milligrams intended for diabetics.
Correct. And so if you're using those higher doses, but we're using, again, 2.5,
5 milligrams, 5
7.5,
milligrams.
like really we're
Very
going,
low dose.
Yes, yeah. And it's a weekly injection. I don't think we ever mentioned that yet. So weekly injection, I think those weight loss studies show it to be a little higher than we're using. You're using a low dose to just help people develop healthier habits along the way. So intermittent fasting, going longer periods of time without eating, instructing them that eating at night increases your cortisol, increases your weight. And so there's lots of different things and conversations to be had. So it's not a quick, hey, here's your prescription and take this amount.
And with that we're talking Tirzepatide. With Semaglutide, we're using even lower dosing.
Correct, yes.
So I just want to point that out. When we say 2.5, that's max dose for Semaglutide, where that wouldn't even be a starting dose for Tirzepatide.
She is correct.
I do want to point that out because some of you are probably like, I'm on Semaglutide and the max dose is 2.5. So that specifically was one medication that we're talking about. Even with Semaglutide, we're going significantly lower.
And when we're looking at that, so we're looking at Surmount-1, Surmount-4. One showed, again, weight loss in the percent range of really a bariatric surgery. So like if a band got a 17% loss, Tirzepatide was approaching, that like 20%. And so now we're talking surgical type results. So it gets attention, but Tirzepatide was studied in that one and weekly dosing, and that's where it was higher. And the Surmount-4 was a study, and both of those also had the drug companies involved, which is how you
grain
get
of salt, right? When you're reading some of these,
which is why you get studies, is because it's sponsored by something, which is why some things that are not that are natural are not studied as much.
Yep.
So, but basically, with the Surmount-4. Then you had, they looked at, again, did it persist? Because that's the other big thing, is as soon as you come off of them, that you gain all the weight back. So Surmount-4 looked at that again, grain of salt, drug company sponsored. So they did up to 36 weeks. They lost, I think, about 20%. These are just, quick facts. And then from 36 to, I think, 72 weeks or 80, I think it was 80 weeks, 80, a little bit beyond, then they gained like 14% of that back, where if they continued on, and that was a double-blinded placebo-controlled study, that they actually continued to lose 5.5 pounds. I think, again, making the argument with certain studies that you have to be on it long term or you'll gain all the weight back. And so that's one of the hypes. And so I think too much, too fast is bad because you get all the sagging and adverse effects with that. And I think that a shorter course with change of lifestyle habits.
I was going to say, change of lifestyle.
Yes.
You need a comprehensive plan. That is, I think, what is missing from a lot of these studies. So are you going to gain the weight back? if you continue the same lifestyle that got you there in the first place, then yes, the weight will come back on slowly unless you make a change.
Correct.
So with our patients, when we are utilizing these medications, we are doing lifestyle changes, nutritional changes, we're doing hormone optimization, and we're having those conversations and making those changes on the front end. So then when we're coming off this medication, we are consistent with those lifestyle changes so that the weight does not come back on.
Yeah.
So we see great results with our patients. We are not seeing our patients put a ton of weight back on unless they're not doing their part.
Correct. And we, like, again, we've seen a lot of great results with low dose tirzepatide. A lot more in the way of side effects with semaglutide. Some people do well if they have lots of side effects, or they have a plateau that they reach and they really are trying to get to a goal, then we switch them to tirzepatide. Again, our dosing is usually low and kept low for the most part. They can titrate up a little bit. Again, we don't get to dosing, facts on this, because then it's like
Because we're
prescribing.
not treating, we're just educating.
And further, like, again, everything could be a different concentration depending on where you're getting it from. So get that specific information from your provider who writes the prescription. But fitness, resistance, and if you wanted to talk about the protein intake. So, like, again, it's kind of eye-opening if you look at how much protein you actually need to take in, even, at a baseline if you're not active, and then if you are active, but even as you get older.
That's
And
it.
so-
0.35 grams
yes,
per pound to maintain.
To maintain. That's if you're not active.
Yeah,
I
that's a pretty
think that's-
sedentary
yeah.
lifestyle,
So
but that
if
is a
you-
maintenance.
And if you want to increase muscle mass, not just maintain, then it's 0.5 to 0.8. But if you are
And that's
getting...
grams of protein per pound.
Correct. Thanks. Yeah.
Yeah, I'm like, just to
I'll
clarify,
just, like,
because it
abbreviate.
is.
Yeah, I'll be abbreviating
Yeah.
and all the things. So yes. And then if you she's used to, you should see my text. You should see my voice to text. Like,
It's
they are-
Debonese.
Yeah, they
It's
are
her own language. So
They
to
are
clarify
used-
for everybody out there, we're
Yes,
talking
yeah,
about grams
thank
per
you.
pound so that these numbers make sense when you're listening.
There's only like 2 people that can actually figure out what I'm saying by text. And-
I'm one of
yeah.
them, and the other one is also in this room.
Yes. So if you're age 50, so as you're getting older, though, again, 1 gram per kilogram.
For very active, for our more
yes.
active. But as we age, we do need more protein intake. So
Correct.
if we are 50 or older, that 0.35 is not enough to maintain. It is,
Yes.
and we really need to be increasing our lean muscle as we age
Mm-hmm.
to support healthy aging. So really that 0.5 to 0.8 per milligrams of protein or grams of protein per pound is really what we should be aiming for. And then the more active you are, obviously the more protein intake you need.
Yeah. So I think as you're hitting those hormonal declines, 1 gram per pound or per pound of protein. But if you hit 0.5 or 0.75, you're probably doing pretty good, because I don't think people often take that in. So resistance training, intermittent fasting, but protein intake, and that's part of healing too. Why do we not heal as well when we get older? It's because,
Not enough protein, not
Yeah.
enough vitamin D, not
Yeah.
enough omega-3s. Those are 3 really big things that are important in muscle building and muscle maintenance.
Yeah. So again, when I see all the negative hype over these agents, I get it, but I disagree with a lot of it, because we are seeing great results and we are not seeing muscle loss and excellent results. And we actually do in-bodies and body compositions, and we follow them, and
We have a
follow our
bod
patients
pod that
every-
we were able
yeah.
to utilize, but in office we do an in-body, and we are not seeing these huge changes in loss of lean muscle. And if we are
correct.
starting to see that decline, we are going back and re-educating with that patient, talking about protein, talking about weight resistance, talking about how do we incorporate that into our lifestyle, or do we need to pull back the medication? Are we going too fast? Do we need to readjust? So these are the conversations that should be had. There needs to be a standard, right? These are not subjective thoughts that we have. We're not just saying, oh, we're not having muscle loss. No, we're doing body measurements, body composition measurements that we can look at
Yes. Yeah.
monthly, quarterly. I mean, regularly, that we're holding people accountable to, us and our patients.
Yeah, I think accountability is huge. Guidance is huge. Doing it safely, but every 3 months at least, we're doing blood work visits and in body composition. We love and look forward to the comments on this topic because it's a hot topic. There's lots of opinions, and we have very strong opinions as well. And so we look forward to hearing what you have to think in your experience, and like and subscribe to share with
And if
friends.
you disagree with us, Go right ahead. We'd love to have the conversation in the comments as well, or do another podcast on something more specific if you'd like to hear more information on something.
What I would love to hear is I'm all good with different opinions, but I would go based on the fact that if you do it right, you do it in low dose, you're doing it comprehensively. Is there science to support the safety concerns with it? And so that I would love to see, because I haven't seen, and there is a thyroid black box warning, but again, when you're talking about, and it's, again, a certain type of, cancer with thyroid, if you have it, of course, you don't want to use it. Pancreatitis, there's some contraindications, of course, a patient being evaluated before they're putting
because not everybody is a candidate for this medication.
Correct.
So that's what's important about seeing a provider, doing this under medical supervision, because you should be screened. There are some things that are contraindicated that you should not be on this medication for.
And not all of our patients. There's just a small subset of our patients that are on it. So not every single one is on. You hormone optimize. Maybe it's just body composition. They don't need to lose a lot of weight. And then it's different peptides if they need it, or just, lifestyle changes. But again, looking for the science, because there's a black box warning, but that's if you're really on it chronic, and or like if you're looking at that chronic treatment. So, but again, making sure there aren't contraindications.
But all medications have their pluses and minuses.
Yeah,
right?
and so I would love links to studies that you see safety concerns documented, because I have not seen those, in like a low dose in a comprehensive way. So, and those would be great studies to look forward to as well from Eli Lilly and
there was a study even that I pulled up that showed if out of all of those millions of people in the U.S. that are obese, if we took out of that 600 million, that 92 could potentially be eligible to be on semaglutide or tirzepatide or one of these GLP-1s. 92 million. That, and if out of those we could reduce cardiovascular risk disease, stroke, heart attack by 1.5 million over 10 years. I mean, those are huge numbers to think about. If we can decrease obesity and treat people for obesity in a way that is sustainable, then we can reduce heart attack risks, stroke risks, by 1.5 million over 10 years. That is a huge number. So think about all the healthcare costs associated with this as well that we can reduce just by treating obesity.
And the AMA is pushing for a lot of that.
Absolutely.
Right?
I saw something as early as in November of 2023 showing that the American Medical Association do have people lobbying for insurance to start covering this, because the associated health costs, the associated health risks with obesity, just having the insurance guiding physician-patient relationships and choices, right? Being able to treat appropriately, the right medication for the right patient at the right time. So there is a huge support from the medical community to get better coverage for this medication.
Yeah, and it would be nice for them to change. We need a lot of changes in the medical system, and nutrition, fitness, other things being covered would be nice too.
Oh, absolutely.
Yeah, so,
this is just one of many things that should be covered for people to help with this.
Education.
Education's big too.
All of that. So, well, we look forward. We could go on forever.
We have a whole soapbox on insurance, right? We could go forever.
Yes. So share your experience, share your comments, share with friends. And again, let us know if you want to hear anything else specifically, because we're willing to deep dive into anything wellness. And thank you for listening.